Welcome back. You're watching McLaren Port Huron's Today's Health, and in this segment we're going to be talking with vascular surgeon Dr. Giliberto, and we're going to be talking about abdominal aortic aneurysms. That's a mouthful. And I'm wondering about the anatomy so people can know what we're talking about.
Okay. The abdominal aorta, the aorta starts at the heart, and it is the main blood vessel from which all other blood vessels emerge. In the chest, we call it the thoracic aorta, and then as it passes through the diaphragms into our abdomen, it's known as the abdominal aorta. And 95% or so of all aneurysms outside of the brain occur in the abdominal aorta.
Well, let's talk about what is an abdominal aortic aneurysm then.
Okay. An aneurysm is an abnormal dilation of the blood vessel. If we think back, some of our peers may remember blebs on the sidewalls of tires, and that bleb, as it got bigger, became scarier looking. Well, an aneurysm is kind of like that. It's an abnormal dilation, and the bigger it gets, the more likely it is to have a complication, and most commonly that complication is a rupture.
So are there other risks of, and who is at risk for an aneurysm?
Aneurysms occur in about 3 to 5% of the population, so it's not a big number, but the problem with aneurysms is that if an aneurysm ruptures, 75% or so of those patients do not survive that event. So it's a very dramatic event. And it's more common the older we get. There are some connective tissue diseases. Maybe people have heard of Marfan syndrome or things like that. Those affect the blood vessels as well. But aneurysms are related to age and sometimes blood pressure issues.
So do they always grow?
No, aneurysms sometimes will stay stable for extended periods of time. So when we find an aneurysm, if it doesn't reach a certain size, we follow it. And the easiest way to follow it is with an ultrasound. Again, no radiation, safe, non-painful. And when it reaches certain sizes, that's when we would recommend intervention. The idea of intervention is to treat it before it ruptures.
Mm-hmm, absolutely. So how might a person know they have an aneurysm? What are the symptoms?
Unfortunately, there are no real symptoms with an aneurysm in the abdominal aorta. Sometimes it'll cause back pain if it expands quickly, but most people don't know that they have an aneurysm. People who are quite skinny, you can feel an aneurysm. You can feel this big pulsatile mass in their upper abdomen, but not all the population can you feel the aorta, so oftentimes they're diagnosed when evaluating for other problems. With a CAT scan is a very common source of identification of aneurysms.
So I have to ask you, since not finding an aneurysm could be fatal, are there screening programs for that?
Yes, Medicare has allowed for a one-time screen of an ultrasound screen of the aorta if the patient is of Medicare age and has smoked at least 20 cigarettes in their lifetime. They will pay for one screening ultrasound. So if it's normal, the chances of you developing an aneurysm are quite small. But if you do have an aneurysm, then you need to be followed. And that would be a reimbursed procedure under most insurance plans.
So obviously, other than age, there are other risk factors for an abdominal aortic aneurysm.
Genetics.
Really?
So if there's a family member, if one of your parents had an aneurysm, typically we generally recommend screening ultrasounds beginning at the age of 50.
And so does smoking make them worse because it makes the vessels?
You know, it's not uncommon to find aneurysms in smokers. But it's basically thought to be due to more of a biochemical process that as we get older, certain things change.
How do you make that diagnosis? And you've talked about ultrasounds. Is that the definitive way?
Ultrasound or CAT scans. Okay. As far as radiology is concerned. If you're of a certain body habitus, they can be felt. So, but to be confirmatory, you do need an ultrasound or a CAT scan.
So then the treatment options.
In days gone by, it was a very arduous surgery. The surgery works well, but it was a very extended hospital stay, 5, 7, 8, 10 days, oftentimes with 2 or 3 day ICU stay. Now we can, with 2 very small incisions from the groin, advance catheters and deploy what we call stent grafts. It's kind of like relining it, and most people are treated that way today. Most people go home that same day or the next day, and it is a tremendous advancement in the treatment of aneurysms.
So is that treatment available for people that even have large aneurysms?
It's not the size of the aneurysm that determines whether or not the patient is a candidate for one or the other. It's other anatomic factors.
Okay, so then, and obviously you as a vascular surgeon would have to work with the patient on what are their treatment options.
Right, and that's all based on CAT scans. And we can get all the measurements we need from a CAT scan. As I say, 95% of all aneurysms can be treated with this less invasive way.
Is there any other, like if a person has an aneurysm, like probably for me, I would be thinking about that aneurysm. Is it growing, is it not? Is there anything that the patient can do to manage their aneurysm?
No, it's going to do what it's going to do, whether or not you jump out of airplanes or lay in bed all day long.
Okay, all right, so that is not something that you can try to impact.
Correct.
And is that something that the vascular surgeon would watch over time? And how often do you have to have those?
Well, the vascular surgeon can do that. The family doctor can do that. We typically will follow patients yearly. In females, we tend to intervene when the aneurysm gets to 5 centimeters. In males, 5.5 centimeters. So as they get in females, so at 4.5 centimeters, we screen them every 6 months. We go from 12 months to a 6 month, and so we keep a closer eye on it the closer it gets to size of intervention.
Given us lots of great information. Do you have closing comments for our viewers?
Peripheral vascular disease can be prevented to a great degree, and this has to do with our lifestyle choices. Smoking, if I could take away tobacco from the United States population, our healthcare costs would plummet over time because of all the health-related diseases. So if you're a smoker, please please stop, and if you're not a smoker, please don't start. Do the other things that you've heard so many times from so many other sources. If you're diabetic, control your diabetes. Lose weight if there's an opportunity to do that. Control your blood pressure, your cholesterol. Those are very important in preventing and helping to treat peripheral vascular disease.
Thank you so much for joining us today.
It's been my pleasure, and I hope it's been informative and helpful.
Absolutely. And thank you for joining us today. You know, if you'd like to watch any segment of this program again, you can always go to our website, or you can get great reliable health information, and that's mclaren.org/PH video. Or you can call us at Health Access, that's 1-800-228-1484, and ask any questions that you'd like to about this program, make a suggestion for a topic of another program. As always, we hope you join us again next week for Today's Health. Today's Health is brought to you by McLaren Port Huron, doing what's best. Yay!
Thank you, Barbara, for allowing me to meet you folks and